Thanks, Mr. Chairman. Ms. Parisho, could I talk a little about telehealth? And in Wyoming, like Montana, it's an important access point for care. It really does help our Medicare beneficiaries with specialty services. I think that in 2021, Department of Health and Human Services reported about 29% of Medicare telehealth services in Wyoming were provided by an out-of-state provider, which is of concern if you some kind of a crisis where you actually need hands-on care right there. HHS has stated that high rate of outsourcing is likely reflecting of a shortage of availability of specialties. That's exactly right. I'm concerned about relying too heavily on telehealth. It's important, it helps us, but are we worried about the issues? So given the challenges you face in Montana, we face in Wyoming, how are you dealing with it from a standpoint of workplace shortages?
We get a lot of questions. We talked a little bit about the licensing, the interstate licensing and cross-border licensing, and I think that is one of the challenges is finding specialists licensed within that state. In terms of workforce shortages, there are, since the pandemic, multiple providers that are providing only services via telehealth and being licensed in multiple states. And until we have some sort of solution to the cross-state licensure, I think that's the solution for now.
Yeah, because I think, Dr. Morone, in your opening statement, you talked about 5% of physicians have closed their physical doors to become full-time telehealth providers. So I do believe there's real value as well having telehealth, but also the direct hands-on patient care component of it. So, it's interesting. Having practiced orthopedic surgery for 24 years, I feel I could go back and do the surgery. I'm not sure I could do the computer work or the technical aspects of filling in all the spots. So the latest estimates are that doctors are now spending about 20% of their time inputting patient information into electronic medical records. Our office, we did electronic medical records before it was a thing. We wanted to be on top of things. The Economist magazine, their annual health barometer, one of the greatest barriers that they identified was that solutions aren't always designed with the need of clinicians and patients in mind. So I find it especially true with increasingly complex, fragmented systems required to provide telehealth. So what existing telehealth services do you think serve more as barriers rather than solutions? Do you see those out there in some ways?
Yeah, Senator, I think you're raising a real key issue here related to the administrative burden and the practicing of medicine. And I do think that we do have to be careful. One of the reasons that I've been enthusiastic about expanding and getting rid of some expanding geographic rules and conditions is because right now there's a little bit too much thought process and administrative burden. Oh, can this telehealth visit get covered? Oh, that's mental health, but maybe it's substance use. There's a lot of nuances there which don't translate well to clinical care. And so I do think we need to be thinking about the administrative burden when we're thinking about telehealth policy. It's a key issue.
Yeah, because they're spending that much time saying, how do I fill this out? It's time that they're not in direct patient contact and doing what they want to do. If they're still trying to get home to be with family, friends, do other activities and not feel overwhelmed or burned out, which is a key part of it. So thank you. And then Dr. Wallace, if I could, you and I are both invested in improving patient care, improving outcomes. There are 60 of us in the Senate who've co-sponsored bipartisan the CONNECT Act for Senator Schatz from Hawaii is the original sponsor. A number of us have co-sponsored. It addresses patient care outcomes. It allows for remote patient monitoring for people with chronic conditions. Remote patient monitoring, I think, is one of the most innovative and cost-effective solutions to chronic care management. It's trying to be used around the world where the technology is available. So as somebody who specializes in the treatment of chronic conditions, can you discuss how using remote patient monitoring for your Medicare patients would impact your ability to treat them?
Thank you, Senator. I 100% agree with you. So the University of Alabama at Birmingham has a remote patient monitoring program that we started in 2018. What we did for Medicare beneficiaries, specifically our accountable care organization, which has 17,000 beneficiaries, we actually identified patients with heart failure, chronic kidney disease, diabetes, hypertension, and congestive heart failure. We subjected them to remote patient monitoring and ended up saving $1,300 per member per month using remote patient monitoring.
Per member per month.
Per member per month. The other thing is that when you look at the number one causes of end-stage renal disease in this country, it's hypertension and diabetes. So we have over 400,000 end-stage renal disease patients at a cost of $80,000 per patient per year. So remote patient monitoring, if we're able to address hypertension, which in our program we were able to reduce the patient population systolic blood pressure by 9 millimeters of mercury in the first 45 days. If we're able to address chronic kidney disease from hypertension and diabetes and get them under control, maybe we can reduce the amount of end-stage renal disease, which ultimately, even one patient off dialysis will pay for a whole lot of remote patient monitoring.
Well, and if you have that kind of a decrease across the board of the systolic pressure, you know how many strokes you've prevented as well in the process, which is an additive effect.
Absolutely.
Thanks, Mr. Chairman.
Thank you.